Okay. Thank you all so much for joining us this evening. It is 7 o'clock Eastern, so I think we should go ahead and get started. Thank you again for joining us. We're so grateful to have Dr. Poller here discuss genetic testing for prostate cancer and the PROMISE trial. A couple of items I wanted to note were, first, at the end of the webinar, we will be playing a short video. The sound on the video is a little quiet, so you might need to turn up your volume a little bit, or the video does have subtitles so you can follow along. Second, Dr. Poller at the end of the webinar will be answering questions about genetic testing in the PROMISE trial. So just please submit those questions in the Q&A function at the bottom of your screen. Okay, it is my privilege to introduce Dr. Channing Poller. Dr. Poller is Associate Professor of Oncology and Urology at Johns Hopkins University, Sidney Kimmel Comprehensive Cancer Center, and Associate Director for Oncology of the Johns Hopkins Clinical Research Network. She is a clinician scientist focused on translating basic scientific findings into treatments that will improve clinical outcomes and reduce toxicities for men with prostate cancer. Dr. Poller is a lead investigator of the PROMISE study, and as an expert clinical trial design, she leads multiple clinical trials of innovative new treatments and treatment combinations employing germline and somatic biomarkers. She earned her MD at Harvard Medical School and completed her medical residency and fellowship in medical oncology at Johns Hopkins. All right, now it's time for the webinar. I'll go ahead and we'll go and get started.
Well, thank you. I'm really delighted to be here today, and thank you for the opportunity to speak with you. I lead clinical trials of many potential drug breakthroughs, and they all matter. But I'm really especially excited today because this is one of my favorites. It's easy, and for an audience focused on prostate cancer like you all, has the potential to directly help you, help your families, and provide information that will help future patients. And that's because precision medicine has now become a reality in prostate cancer. In 2020, the world of prostate cancer was transformed with 2 new drug approvals that target mutations in DNA. And we launched the PROMISE registry this year as a way that you can learn about your DNA and whether you might have an opportunity to receive targeted treatment for your prostate cancer. At the same time, you'll be contributing to improving the diagnosis and treatment of prostate cancer for other patients, including your children and grandchildren potentially. I treat prostate cancer patients and manage a research program focused on identifying biomarkers, including mutations in DNA that can be targeted to help us cure more prostate cancer patients, or at least help them live as well as they can, as long as they can. It's great to launch this program with PCEC because for more than 30 years, PCEC has done an amazing job of helping to broaden access to prostate cancer screening across the country. One of your goals is saving lives through awareness and education of men, loved ones, as well as the medical community about available treatment options for prostate cancer, whether that be standard of care or clinical trials. And so this becomes even more immediate and important in the age of precision medicine as more and more therapies emerge. So what are we going to talk about today? Well, 4 things. First, we're going to understand how your genes help determine risk of prostate cancer and also how they help identify treatments. Then we're going to meet a couple patients to understand how genetic testing can lead to treatment with targeted therapies. And third, we'll look at what PROMISE is and why it might be right for you or someone you know. And finally, I'm delighted that we'll be able to answer questions and have a discussion. So to get started, I'm going to talk about why your genes matter. When I ask audiences whether they know their blood type, somewhere between 1/2 and 2/3 know it, usually because they know that blood type matters and they know if they need blood transfusions or not. In fact, giving people the wrong blood type causes hemolysis. That means that it can destroy even more of your red blood cells and lead to terrible complications and in some cases death. In other words, when it comes to blood transfusions, one size does not fit all, and you need to pick very carefully. What I will share with you today is how your genes, specific variations that you may have in your DNA, can be just as important as blood type. And in fact, you will see in the patient stories, patients with specific variants can be eligible for life-saving therapies. So here you see a selection table for which types of blood may be infused into patients with other types of blood, You may not know that ABO blood type is controlled by a single gene. I didn't long ago, but now I do. However, you may have heard that the BRCA gene that gives women an increased risk of breast cancer also has other impacts. So when patients inherit a BRCA2 mutation specifically, then the patient and potentially their children and siblings could also have a much higher risk, not only of breast cancer, but also prostate cancer, pancreas cancer, and melanoma. So in other words, natural differences in one gene can change your blood type. And I think you can understand that other changes determine whether individual cancer treatments would work or don't work, and whether or not you or your family have a higher or lower risk of being diagnosed with cancer or even an aggressive form of cancer. So several years ago, we learned that BRCA2 is a gene that increases your risk of prostate cancer. That's the bad news. The good news is, as I mentioned before, we have two new pills, rucaparib and olaparib, approved by the FDA, that people can take in the comfort of their own home and control their prostate cancer. So 5 to 10% of the time, cancer is caused by a mutation in a cancer-protecting gene that you inherit. When that variant is passed down from people's parents and may have been passed down from their grandparents, we call that hereditary cancer when it's enabled by a germline mutation. That is, mutations you were born with. There are other types of mutations called a somatic mutation, which is an alteration that happens after you were born. We can talk about those in the question and answer section if you are interested. But what makes the program we're talking about today so easy for patients is all that it takes is a little saliva that you provide at home, and then it determines if you were born with the variants that we know matter and are important to your care and your family's risk of cancer. What I also like about this is if you do find out that you have any hereditary risk factors, the program provides free genetic counseling to help you and your family navigate this new information. So how does this work for my patients? How is genetic testing enabling us to do these new treatment approaches? So before the age of precision medicine, clinical trials and FDA approvals have resulted in our being constrained, for the most part, to a one-size-fits-all approach in treatment selection. We saw over and over those therapies only work for some of the time. In fact, sometimes it helped patients, sometimes it did nothing, and sometimes it actually harmed people. So for prostate cancer patients, this is true for both chemotherapy and testosterone-lowering therapy. When a treatment stops working or when it doesn't work at all, we often move on to a different treatment. And what we'd like to do is make the right choice the first time so that we give the patient the best possible, most effective treatment with the least possible side effects for each person's genetic profile. So even after we've had new lines of therapy called androgen-directed therapies, including ones you might have heard of, enzalutamide and abiraterone, and several newer ones, it wasn't until 6 or 7 years ago when my colleagues and I first identified the ARB7 variant of the androgen receptor as a biomarker, when we were able to determine whether these new androgen-directed therapies were less effective with increased toxicity than, say, chemotherapy or some other treatment for individual patients. So that's really the goal of precision medicine, to better understand who will respond. So if we can identify which mutations to target with each treatment, we can have a much more positive impact on both survival and quality of life. As you can see from the graphic, matching the green medicine to the green people is moving medicine away from the one-size-fits-all approach towards more precise and personal treatments. This is done by gathering your genetic information and creating a DNA profile, which can then be seen by doctors when determining a course of treatment. This then allows doctors to suggest different therapies based on your individual factors so that there are more positive outcomes for patients. In fact, when drugs are co-developed with a genetic biomarker, they are more likely to receive FDA approval because we know who is likely to benefit from the therapy. You might wonder why you see colon cancer on this slide. Well, it's because in 2015, one of my colleagues in the world of colon cancer, Johns Hopkins, figured out that a specific mutation in her patients resulted in a beautiful response to targeted therapy with immunotherapy. At my request, she opened this trial to some of our prostate cancer patients who also carried that rare mutation and found that they also responded to immunotherapy. That and many other patients and trials led to the FDA approval of pembrolizumab, the immunotherapy being tested for patients with any type of cancer who carried that specific mutation. That's one of the reasons why we now do genetic testing on every cancer patient. So let's look at a couple of my patients. So without sharing any names, let me share a couple stories, and I got their approval to talk about them without names with you guys today. So Mr. B is 92 years old. He told me that he'd lived a good life, but was done. He'd come into the hospital with pain and a PSA of 1,000. He told me he did not want any other therapy. He did not want to come to the hospital. He did not want to come to clinic. He wanted to spend time at home with his family and be at peace. I said that all of those points were extremely valid, reasonable, and I wished I could live to the ripe old age of 92 as well as he did. However, I then challenged him and said, what if I could grant all of your wishes and help you live as well as you can, as long as you can, and keep you around a little bit longer for your children and grandchildren? He agreed to provide me a saliva sample, which allowed me to test for genes that have a targetable mutation, the two we talked about, rucaparib and olaparib. I agreed to enroll him in hospice while he was waiting his genetic results. Well, as it turns out, 4 weeks later, he had a BRCA2 mutation. I was thrilled to let him know that in the comfort of his own home, he could take a pill called olaparib to control his prostate cancer. Olaparib is approved for patients with BRCA2 and 14 other DNA repair-related mutations, but does not seem to be effective in patients without those mutations. He did well. His PSA came down dramatically, and he felt much better and pain-free. And then he is 92. So then he told me, I'm tired of taking this pill. It's just a little too big. And at first I fought him and said, seriously, you're doing so well. Please take the pill. But eventually I did some research with my clinical pharmacist and learned that the alternative, which was new on the scene to me, rucaparib, was slightly smaller. He tried it, and it is much easier for him to swallow, and he continues to take it today. In fact, his daughter wrote me a note last week that I'll share just one paragraph with you. She writes, hold on one second. It's an amazing difference from January when he thought he wasn't going to make it. The best way to describe it is he's had a bit of return to his 1960s lifestyle. He's now had his bridge friends over at least 3 times in the last few months. I'm quite surprised. This is a very serious game. They played for 2 hours, rotating chairs and observing all the rules. His friend Sam, who hadn't seen him in person for a year from before he was hospitalized last July, said, your dad seems to be doing great and his health seems much improved. And she responded, it's the new wonder drug he's on, and they all wanted to know more. She adds, P.S. the interesting thing will be he gave his golf clubs away to the caddies at his club in January, saying he would never play again, but we'll see. I can give you an update on that one. I really appreciate how lucky Dad was to have the mutation for this pill. So that's my, I always like the 90-year-olds. How do they live that long? And what are their secrets? So I love hearing their stories. I have one other patient, much younger, and his name is Mr. D. And he appeared with what we call biochemically recurrent prostate cancer. So that's when your PSA is rising after surgery and or radiation, and you can't see it, but you know it's there. And it's quite stressful because you don't know how to fight it because the PSA is rising, but you can't see it. So the standard of care usually in that space is intermittent or on and off hormonal therapy. But he really did not want hormonal therapy. He did not want to lose his sex life. He did not want to lose muscle mass. He did not want hot flashes. Who could blame him, really? And so I tested him for genetic mutations and found that he too had a BRCA2 mutation. And that actually made him eligible for one of our clinical trials that we have, where you were allowed to take olaparib as opposed to intermittent hormonal therapy to see how well you respond. His PSA turned out that it stabilized, his scans stable, no evidence of cancer on his scans, and his testosterone was normal, and he was thrilled. And so that is sort of a happy story. We don't know how long it's going to last, but it is wonderful that he is able to receive treatment for his prostate cancer without the terrible side effects of hormonal therapy, at least for the time being. So now I'd like to share with you what PROMISE is. In case anyone asks you, what is PROMISE? PROMISE stands for Prostate Cancer Registry of Outcomes and Germline Mutations for Improved Survival and Treatment Effectiveness. It's done all over the country and being led by Heather Chang at University of Washington and myself at Johns Hopkins. So there's wonderful new research that allows us to bring precision medicine into the fight against prostate cancer. We do this every day with our patients at Johns Hopkins, and what Promise lets me do is bring that benefit to you in the comfort of your own home. It allows you to find precision or targeted treatments and help inform and protect your family. It also allows you to become part of the solution that we're all looking for in the fight against cancer, because what you do provides data that we can't get anywhere else. Some of these mutations besides BRCA2 are very rare, and it really takes a group of people working together to find out more information about those mutations. So I hope through this briefing and the discussion today, you will see that Promise offers an opportunity that you will want to take advantage of and that you will register. When you do, we will send you a DNA test kit, and all you need to do is send a saliva sample back. In return, you'll get information tailored to your DNA, not just once, but continually as new treatments and opportunities arise that are tailored to your DNA. Your doctor will also receive the results and research updates relevant to you so that you guys can decide together if there's anything that you want to pursue. Also, if you don't have any mutations, that's great news too. You can probably opt in to receive information from our newsletter as well, from the Prostate Cancer Consortium, because we're providing all these information about clinical trials. So the two principal investigators on this study are Heather Chang and myself. Dr. Chang and I both work with prostate cancer patients and work closely together on trials, learning more about germline genetic testing for prostate cancer patients, both to assess their cancer risk for them and their families, and to match patients to clinical trials that may lead to new drug approvals like rucaparib and olaparib that were approved in May of 2020. So now that you all have a better idea of what Promise is, I want to talk about a few key points about why Promise might be right for you. So the reason why Promise exists is because learning about your genetic information could ultimately end up saving your life or you to get prostate cancer, because treatments could be taken that your genes might respond to. Prostate cancer can be inherited for many, and getting prostate cancer was written into their genes from the beginning. However, so are the instructions for treating it many times. And by finding these instructions through collecting genetic information, new treatments can be discovered and used. There are also 4 other key benefits related to genetic counseling. So what is genetic counseling, you ask first? Well, genetic counseling involves working closely with a genetic counselor or other healthcare professional who will collect your personal and family history along with your DNA, and then use this information to determine the likelihood of you or your family member getting a genetic condition. Genetic counseling can be very important, has many benefits. First, it increases your understanding and simplifies concepts of genetics and hereditary risk. It also allows for you to address any questions or concerns about genetic testing or your DNA results. Next, it provides free counseling that improves your decision-making and empowers you to make informed choices about you and your family's health. And third, it helps you assess inherited risk for family members. Finally, genetic counseling provides you and your family with a new and informed perspective in a supportive way. So I think joining Promise is a no-brainer because you get genetic counseling for free and you get your physician and you informed in a way that potentially could personalize your treatment. And if you don't have any genetic risk factors, then no worries, that's even better. So all you need to do to join Promise is complete an online form and send in a saliva sample, and we do the rest. In addition to gaining knowledge on your genetic profile and having access to a genetic counselor to review it with you and your family, the new information can impact available treatment options and give you a higher chance of survival. In the fight against prostate cancer, information is the most powerful tool, and Promise will help you discover more information and use that tool. You will also receive the most current information about new research, clinical trials, and treatments approved by the FDA via regular newsletter. We will also ask for updates every quarter to 6 months to get information about how you're doing so that we can better get data on each individual mutation that are more rare. And we really need a group to ask those questions, working together. So as I wrap up my presentation, if you have prostate cancer, I would like to ask you to join Promise to aid our study, as well as gain beneficial information about your genes that you and your doctor potentially could use in the future. Our website, prostatecancerpromise.org, is located at the bottom of the slide so that you can investigate further. And this will conclude my presentation. I'm going to go ahead and show you the website and the information video so that you can have a sense of what the video includes and what this is all about. So thank you so much for joining, and thank you so much for inviting me. It's really a pleasure to be here today. So I'm going to go ahead and pull up the website. So here is the Promise website. As you can see, across the top is what we're all about: research, different research opportunities, how it works, frequently asked questions, and there's a join us button in the top right and a join us button in the middle. As we scroll down, let's watch the
Over 4 million American men are fighting prostate cancer. For many, the disease was written into their genes, but so are instructions to help us discover more about prostate cancer, how to treat it, and your own family's risk of developing the disease. That's why learning more about the genes of men with prostate cancer is so important. And it's why Promise was formed. Promise is a registry of prostate cancer patients who joined a research study to advance knowledge about the role our genes can play in health outcomes. It's a collaboration between you, your doctor, and researchers from Johns Hopkins University and the University of Washington. We're asking prostate cancer patients to share their genetic information, their DNA. Your DNA could unlock knowledge about prostate cancer, guide the discovery of new ways to treat it, and help to predict your family's risk of developing. Promise is completely free. Your information will only be used for research and will never be sold to a third party. And you don't have to leave your healthcare provider or even your house. Joining Promise is simple. 1, get registered. Learn if Promise is right for you and register online. 2, get the DNA kit. We'll send you a DNA test kit. A saliva sample is all we need. And 3, get results. You'll receive information tailored to your DNA that helps you understand your disease better. Get started today.
All righty. Thank you so much, Dr. Poller. All right, well, we'll go ahead and do some questions that have come in, and we had even some submitted before, so we'll go ahead and hop right into those. I want to make sure you are unmuted though. Yep, you're good. Okay, so I'm going to go ahead and start with a few questions. First, we had one asking, just kind of, can you go over the general basics between what is the difference between somatic and germline genetic mutations?
Sure, of course, Lindsay. So germline mutations are the ones that you're born with, that come from your parents and your grandparents, and they're in all the cells of your body. Somatic mutations are ones that develop after you've been born, and oftentimes it takes 1 or 2 or more somatic mutations to make cells become more aggressive and turn into more aggressive cancer. And so the difference is really whether you were born with it, which is rare, or it develops over your lifetime.
Thank you. And if a patient has tested positive and has a mutation, when and should their families be tested? And if so, when should that testing occur?
That's a great question. And it really is dependent on multiple factors and should be discussed with a genetic counselor in terms of the penetrance, how aggressive this gene is, and the different genes need different screening for different cancers. A good rule of thumb is 10 years before the relative got cancer, you should be screened, or the siblings or children should be screened. So that's sort of a good safe rule of thumb, at least 10 years before would be one that you can keep in your back pocket.
Thank you. And a lot of the attendees on the webinar, they're at various places in their kind of prostate cancer journey and treatments. So kind of just sum up those questions, when should a patient be tested for genetic mutations? Do you do it really early, like right out the get-go, or should you wait until you're a little more advanced and into a few treatments?
So that's a great question, because all of us would answer this differently, as has been published many times. And the reason is that right now, these drugs are only approved for advanced prostate cancer, meaning after hormonal therapy has stopped working as well as it should. So the insurance companies pay for it later, but they also recommend for high risk, because it may affect how often you should be screened. They recommend it for Ashkenazi Jewish history, for certain cancers in your family history. So ultimately, the guidelines recommend, if you're high risk, so these are the NCCN guidelines for those of you who are familiar with NCCN, high risk or very high risk regional cancer or metastatic cancer, everybody should be screened. Ashkenazi Jewish ancestry or a family history of Lynch syndrome or BRCA1 or 2 mutations. The other one that's sort of a suggestive recommendation is cribiform histology. The pathology shows a special type of histology. And then, of course, significant family history of prostate cancer. So all of those things suggest that you should get germline testing within the guidelines. At Hopkins and at many other academic centers around the country, we test everyone who walks in the door with a Gleason score and a biopsy or a PSA over 100, because we have clinical trials that may be able to change the course of someone's disease trajectory, and may be able to give them options besides the standard of care, such as that one patient I told you about who was able to go on olaparib instead of hormonal therapy in the biochemically recurrent space. And so in my practice, I test everybody who walks the door, because I think you should know for yourself, for your family, and it just gives you many more options.
Thank you. If a patient has already been genetically tested, can they still be a part of the trial or the registry if they've already had testing done?
That's a great question. Yes, yes, and yes. So we want everybody. It is a little annoying, I will say, if you've gone through and say had in vitae testing, this is a germline test, and we ask you to do a color test. You say, why do I have to do it? I already did it. We really want to look at all of your genes, both the 30 genes that are sort of commonly known and some rare ones, and that way we have the same data on everyone and can really compare it. The other reason is different tests have different strengths and weaknesses. And so really we want to have one standard test for all participants. But if you've already had testing or if you haven't had testing, you are welcome to join.
Kind of going along with that same tone question, if a person's been tested before but didn't have a significant genetic mutation or variation, would you still recommend they get involved with PROMIS, or do they not? This wouldn't really apply to them?
I think in that case, it wouldn't really apply to them. If they're sort of interested about clinical trials, I think this will be a good source to tell people about clinical trials, but they can also learn from Prostate Cancer Foundation, from the Prostate Cancer Clinical Trial Consortium, which we're a part of. So there are other ways that might be more targeted for them. So I would probably say not those people.
Okay. And then last two questions. If a person isn't eligible for the trial, and genetic testing isn't covered by insurance, what is kind of the price point? You know, we always talk about price, and that is definitely a forefront thought of patients.
Well, this is what the point of this is. It's to say that insurance companies should be paying for this for everyone. And so this is free to everyone. So if they can't afford it, this is a way to bypass their insurance and get free genetic testing to share for them, their families, free genetic counseling, and share with their physicians. And so this really, thanks to the support from Advancing Cancer Treatment, bypasses that need to get insurance approval.
Excellent. So then final question, which you kind of already touched base on, but I guess just like one person's asking, does the PROMIS trial offer new treatments? And you kind of touched base on that it could, right? If we find
right,
that.
So it itself is just a registry. It is not offering you treatments. It is a resource to offer you information about all of the clinical trials ongoing with different targeted mutations in the country. We're going to break this down by region. So if you live in Seattle, you may not want to hear about the trials at Johns Hopkins. And if you live in Chicago, you may not want to hear about either of our trials. You might want to hear about them in the middle of the country. So yes, it'll be broken down by region, and it will provide you with ongoing new drug approval information, ongoing new research, ongoing new clinical trials, ongoing new breakthroughs. And so really it is an information source to connect you to the team that is doing clinical trials of therapeutic options.
Excellent. And final question. How is tumor DNA profiling different from germline testing?
So that gets back to the somatic versus germline question. So when we do tumor profiling, we look in your prostate cancer tumor for mutations that develop, and oftentimes they have different mutations. Oftentimes they have the same mutation, and then they have new additional mutations that are less common. So for example, there are certain mutations like CDK12 that are more common in one versus the other, such as somatic, versus BRCA2 is often germline and less common somatic, but it absolutely can happen. So there are different profiles of mutations depending on if you're looking at the germline versus the somatic, and there are some overlapping. So the Pritchard paper in the New England Journal from 2015 has a nice summary of those if you want to look back.
All righty, I think that kind of sums it all up for us. Thank you so much, Dr. Pollard. We really appreciate your time, and thank you everyone that attended. This was wonderful, and I hope everyone has a great rest of the evening.
Thank you so much. It was a pleasure to be here today.
Thank you.